Good morning, everyone. So, this session, I hope you had a great beginning to your conference. This session is going to be on autism spectrum disorders. And the first presentation is going to be by ELENA, Chloe, Dr. Katerina, and Professor Karola Dillenburger. ELENA is the presenter for the first presentation, first paper.
Thank you. First of all, I would like to thank the mothers and children participating in the study and my supervisor who were very supportive, Katerina and Professor Karola Dillenburger. This paper is now submitted for publication and is part of a PhD research now in its final year. ASD is the most common developmental condition and developmental concern are often expressed by families well before diagnosis. Despite growing awareness of early markers, only a handful of preemptive intervention have shown positive results in reduced ASD symptomatology. For example, Tanner and Dounavi showed positive results using a naturalistic parent-mediated behavioral intervention based on the analysis of verbal behavior. NDBI, as parent-mediated interventions, are considered evidence-based practice, having shown to produce positive changes across all developmental areas, especially communication, social skills, and joint attention. The primary objective of the study is to investigate the efficacy of a parent coaching package on developmental and behavioral strategies used to support early social communication and joint attention related behavior. Second, the impact of the proposed training on the three repertoires identified as weak in participating children. And third, to assess the social validity of the intervention. The participants are two mother-child dyads. Jill was a 12-month-old boy who participated with his mother, Susan. Jack was an 8-month-old boy who participated with Maddalena, 35 years old. Both mothers held a master's degree and agreed to participate in all meetings and conducted 2 30-minute practice sessions at home. And both children qualified as high-risk siblings, having an older brother diagnosed with ASD, already benefiting from ABA-based intervention. Multiple based design across behaviors with intervention effect replicated across 2 mother-child dyads. The intervention consisted of 9 weekly training meetings, and in each 1-hour meeting, there were at least 3 micro sessions of lasting 10 minutes each, plus daily practice by caregivers. And there was also 1 follow-up and 1 generalization meeting. The generalization meeting took place in the family's home, while the intervention and follow-up meetings took place in a small clinic in Bologna, where I'm based. Materials included play materials and toy appropriate for the age of the children, books, and were rotated during successive meetings according to the children's motivation to prevent association. 9 NDBI, naturalistic developmental behavioral intervention strategies, were organized into 3 domains and taught in 3 successive training phases. The first the dependent variable was the parent behavior. DVP consisted in the percentage of 30-second intervals during which the parent showed each of the 9 behavior matching the trained naturalistic strategies and was tracked in a multiple baseline design across behavior. Domain 1 included environmental arrangement, such as materials and space prepared to maximize motivation, the position of the adult, and pauses, and frequent opportunities to respond. The second DVP was related to ABC format, such as suggesting variation to keep the high interest of the child in the play routine, and prompting and reacting with appropriate enthusiasm to responses and attempt from the child. The third DVP related to shared control strategies, such as expanding and reacting to each communicative act of the child, following the child's lead, and narrating. So these are a couple of screenshots from the studies showing environmental arrangement and positioning, showing prompting, and showing imitating the child action. Dependent variable 2 was DVC, so was related to the child behavior in imitation, respondent joint attention, and speaker behavior. For example, imitation action with object, motor actions, gestures, and oral facial movement, showing positive engagement in social exchanging, for example, using motor prompt to initiate or continue play, smiling and staying close proximity, respondent joint attention behavior, such as following proximal and distal point during play. The third dependent variable related to the child was speaker behavior, points or uses gestures to communicate needs, comments with gestures, and also sounds, emitting sounds while interacting, language sounds, and word approximations. Scoring was conducted for each parent-child diet through partial interval recording using 30 seconds interval. Inter-observer agreement was calculated for approximately 30% of microsessions and ranged between 70 and 100% across participants and behavior. Results are shown first for dependent variable related to the parent, then to the child, and treatment fidelity and social validity. These are the graph showing results for the two mothers. Figure 1 represents the percentage of intervals in which Jill's mother used strategies from the environmental arrangement domain. During baseline, the percentage of intervals during which she arranged the environment and the material to maximize motivation and offer a child multiple opportunities to respond never exceeded 10%. In contrast, her use of the environmental arrangements strategies significantly increased after introducing the intervention in session 7. This is the first leg of the first graph. And environmental arrangement strategies usage reached 100% in session 27 and remained stable above 90% in follow-up and generalization. Results regarding ABC format domain are shown in the second leg. Results show that the performance almost doubled during training. The average increased from 20% of intervals during baseline to 38 when intervention on ABC format started, reaching 55 in the last two sessions. The third and last leg of the first graph illustrates shared control strategies employed by Jill's mother. Domain 3 behavior were exhibited during approximately 40% of all baseline intervals with significant levels variations. However, a substantial and constant increase to 74 was observed during intervention, and the newly learned strategies were maintained at above 70% in follow-up and generalization meeting. The second figure illustrates Jack's mother, that is Maddalena, results. All three domains reached a very high percentage of intervals with target behaviors in follow-up and generalization, 100% for environmental arrangement, 70% for ABC format, and more than 75% for shared control. The baseline of environmental arrangement showed a sharp increase in the last two sessions when Maddalena asked for an additional empty box to store toys and materials during play. This might have been related to her experience in ABA teaching with her older son and might have played a role in this request, which was honored since it could help her conduct the sessions. Now we're going to see the results for the children. The first graph is Jill's result. It relates to Jill's result. Jill's showed very few imitation behaviors that are shown in the first leg, imitating action, gestures, or facial movement in less than 10% of the intervals per session. But after the conclusion of parent coaching, during follow-up, a slight increase was observed. Respondent joint attention, showed in the second leg, were present in less than 60% of the intervals of average during baseline. However, a significant increase is shown in the subsequent experimental phases, with scores consistently above 90% from session 29 and reaching 100% in session 38 and 39. The third leg summarizes Jill's results in speakers' behavior. Aggregated data show a decrease at first, followed by a performance equal to baseline during follow-up and generalization. Still, it is necessary for me to share a more detailed analysis made possible by the data collection system that was tracking each single behavior in each domain separately. If we look at behavior separately, we see that significant and opposite changes occurred in non-language sounds concerning language sounds and word approximation, while producing frequent non-language sounds and various communicative gestures at baseline. Jill's emitted very few language sounds or word approximations in the first half of the study until session 17. However, Jill's language production increased during the last two phases of the study that were ABC format and shared control in the training of the parent, and exceeded 50% of the intervals in generalization sessions, showing an increase in language production that can reasonably account for the absence of an analogous rise in communicative gestures. The second graph illustrates Jack's results across all experimental phases. While imitation was almost absent in baseline, it reached 15% in follow-up and generalization. Respondent joint attention behavior doubled from baseline to follow-up and generalization sessions, being present in more than 95% of the intervals in 4 out of the 5 total sessions. Speaker behavior, the third leg, showed a similar pattern, being present in less than 35% of the intervals in baseline and reaching more than 55% during follow-up and generalization sessions. Treatment fidelity reached 100% in all the microsessions scored, that is the 50% of these sessions. Social validity was measured through a social validity questionnaire completed by the 2 participating mothers, while indicators of mood and engagement in children were monitored throughout the study. The intervention was very well received from children and mothers as well. In the context of a global rise in autism diagnosis, the growing awareness of reliable early markers has made it possible to offer preemptive intervention, potentially influencing the developmental trajectory of children with an elevated risk of ASD, such as siblings of children diagnosed with autism. The first contribution of this research is that while previous research focused on fewer strategies, such as on the narration or environmental arrangements or reciprocal limitation or on branded intervention, this research focuses on a vast array of strategies that are more feasible to administer outside of a research context. A second contribution of the present study lies in the considerable amount of behavior-specific data collected through training phases, generalization, and maintenance, as suggested by reviews on naturalistic intervention. This study has also limitation. The first and more evident limitation is that with only 2 mother-child diets, this study can constitute only an initial step in assessing the feasibility, acceptance, and effectiveness of responsive parenting strategies. The second limitation is the lack of diversity in cultural background and socioeconomic studies. In conclusion, in sum, the present study reports on the effectiveness and acceptability of a short training sequence on naturalistic behavioral strategies in the context of play routines. The training successfully increased the use of strategies in both participating mothers and supported social communication behavior during play into infants at risk of autism. Weekly coaching meetings were accompanied by daily independent practice over less than 3 months, showing promising results in maintenance and generalization. So we can conclude that findings support the dissemination of evidence-based strategies to primary caregivers, intending to establish responsive parenting and promote skills acquisition during a critical period. Thank you very much, and I now pass to the second speaker. Thank you.
Thank you, Elena. That was wonderful. We would like to now have the second speaker, Monica MILLAR, who is presenting the second study co-authored with Dr. Katerina Storey and Dr. Nichola.
We can see everything okay? We can hear me?
Yes, we can.
Okay, great. All right. So thank you everyone for joining this morning. So I'm going to be going over the treatment of anxiety for autistic children with an IDD, a systematic review. So this is part of my PhD program through Queen's University with Dr. Katerina Storey and Dr. Nichola. So prevalence levels of, a brief overview of what we're going to discuss this morning. So we'll go through the theoretical framework, some of the previous literature, research questions, methods, results, and then discussion. So prevalence levels of clinical anxiety for children with autism spectrum disorder has been estimated at between 11 and 84%, which is really quite a broad range. The prevalence of children with ASD and an IDD is about 32 to 42%. And researchers have identified that anxiety occurs more often in the subpopulation of children with ASD and IDD when compared to just ASD. Previous research has found the use of psychopharmacological and non-psychopharmacological as the most common approaches. So what we're really looking at is kind of cognitive behavior therapy or medications such as citalopram, fluvoxamine, or buspirone. So when we're looking at the previous research, I put a list here. So Vasa et al. 2014 conducted a systematic review that explored the treatment of anxiety in individuals with ASD. But what they found was there were several limitations to the use of pharmacological treatment. The studies evaluated were limited by small sample sizes, no comparison groups, and presented a range of aversive effects. such as increased activity level or impulsivity. Walters et al. 2015 did a systematic review on CBT and CBT modifications, which aligned to the Institute for Health and Care Excellence. The review demonstrated that CBT was effective at reducing anxiety within one measure, but the limitations in the study was all of the participants had above average IQ. Those results were similar from Kester and Lucician 2018, where they used the standards set out by the Council for Exceptional Children and deemed that modified CBT was an empirically supported treatment for children on the autism spectrum. But again, the limitation within their study was that all of the participants had an IQ of above 75. When we go to the other side, Rosen, Connell, and Kearns completed a literature search to determine the research supporting behavioral interventions for anxiety. So they reviewed 7 studies, and what they found was that behavioral interventions were effective in the treatment of this population. So they were looking at things such as desensitization, reinforcement, modeling, prompting, and anti-anxiety stimuli. And then Moskowitz et al. 2017 evaluated FCPBS and CBT for children with ASD and IDD. So what they did was they created a multi-component behavior support plan to reduce anxiety-related behavior. And they found that this offers initial support towards the effectiveness of FCPBS to treat anxiety-related behavior. So this leads us to my 3 research questions. So what I did for my systematic review was a replication of the work done by Jonko and Storch 2015. So they highlighted the importance that future research needs to focus on understanding whether adaptations to CBT may be effective for those with an IQ of below 75. So these are my 3 research questions. What are the intervention characteristics included in the treatment? Is CBT effective in the treatment of anxiety for children with ASD that fall below borderline or average IQ? And then can CBT be enhanced by embedding ABA or PBS strategies into the treatment? So initial search procedures began in June of 2022 and they ended in July. You can see here we reviewed PsycInfo, ERIC, and PubMed. Studies were initially screened through the title and the abstract, and then we went into full text screening. The inclusion and exclusion criteria for the studies was that participants had to be under the age of 18, have a diagnosis of ASD, IDD, and anxiety or engage in anxiety-related behavior. The studies must have been either published present or in the grade literature, written in English, and have an experimental design. There must have been a reported outcome on anxiety levels. And then the dates was between 2014 to 2022. For data extraction, we initially pulled 710 articles. After screening the title and abstract, that then reduced down to 34. We removed any duplicates, and then a total number of studies included in the review was 6. RICO quality indicator was used to assess the strength of the studies. So we looked through both essential and desirable quality indicators. You'll see along here on the right-hand side that 4 of the studies were deemed as having a weak strength rating. 1 of the studies was adequate, and then 1 of the studies met high criteria. Next, we're going to walk through the results of the study. So of the studies reviewed, we had a total number of 40 participants included. The age range was between 5 to 19, 31 were male, and 9 were female. More importantly, looking at this side, 15% of the participants that were included were identified having a severe intellectual disability, 39% had a mild to moderate, and then 46% were in the mild range. Dependent variables evaluated. So we divided it into 2 different areas. So we had both standardized assessments that were used and then behavioral methods. There was 12 different methods used across the 6 studies, so that's quite a lot. Behavioral measurements included things such as trials to criterion, phobic avoidance, heart rate, or problem behavior. And then a few of the standardized assessments you'll see here, but we had the geriatric anxiety scale, the diagnostic and manual of mental disorders, the screen for anxiety and related emotional disorders, and then Glasgow anxiety scale for people with intellectual disabilities. For intervention outcomes. So our first research question was, what are the intervention characteristics included in the treatment of anxiety for children with ASD and IDD? So we highlighted throughout this, there was kind of 2 different approaches. It was either a manualized intervention or individualized approach. But we noted that both of them occurred for around either 13 sessions or 13 weeks, with the assumption that it was 1 session per week. So the 2 manualized programs that were identified was the Facing Your Fears program and then the Calm Child program. So Facing Your Fears is a manualized program that focuses on CBT group intervention. This was conducted by Blakely et al., and they created 3 main adaptations to the curriculum. So they did structural adaptations, so they reduced the length of the session, they had smaller group sizes. They did content adaptations, so they included a parent curriculum. And then lastly, procedural, so they added in more visual supports, incorporated special interests, hands-on activities. And then next is the Calm Child, which was a pilot program, and it was designed for parents to provide proactive strategies, such as visual schedules, verbal reasoning, explanation, and self-management and self-regulation. And this was an attempt to proactively reduce the anxiety. For individualized approaches, we had a range of about 3 to 14 treatment components in each study, with the average being 6.75. So some of the common strategies that we noticed were the use of reinforcement, the incorporation of an anxiety hierarchy, extinction, and then increasing predictability. There was additional strategies that were noted, such as modeling, response fading, anxiety relief strategies, and functional communication. The second question was, is CBT effective in the treatment of anxiety for children with ASD that fall below borderline average IQ? So again, we had just 2 studies that incorporated CBT. The first one was Blakely et al. And then Moskowitz et al. So Blakely et al. Again introduced the 14-week manualized program that included CBT. What they found was that CBT was effective in reducing the anxiety-related behavior. And then Moskowitz implemented a multi-component FC-PBS and CBT intervention, which their CBT components focused on psychoeducation and graduated exposure. The third research question was, can CBT be enhanced by embedding ABA and PBS strategies? So again, Moskowitz et al. Incorporated the use of both PBS and CBT. What she implemented was a multiple baseline design across participants to evaluate the effectiveness of this approach. And the results demonstrated that there was a functional relation between implementation of these strategies and the CBT plan and improvements in the child's respiratory sinus arrhythmia. So that's really a reduction in their heart rate in the anxiety-provoking situations. And this study offers initial support for the research questions of if CBT can be enhanced by embedding these ABA or PBS strategies. So lastly, we'll go through the discussion. So when we reviewed what were the intervention characteristics for treating anxiety for children on the autism spectrum with an IDD, it was a range of 3 to 14 components. So this aligns with previous work conducted by Moore and Davis 2009, which included kind of common modification trends that needed to be added to enhance the CBT. So that included things such as disorder-specific hierarchies, the incorporation of visual supports, incorporating special interests, increased parent involvement, And really, to me, this just highlights the need to understand more of the effective components that will allow practitioners to provide treatment in a timelier manner and also utilize less resources. So, although these improvements in anxiety pre and post intervention, there's not enough support to claim that CBT is an evidence-based practice. So Horner et al. 2005 requires that a treatment to be established as an evidence-based practice must be supported across at least 5 single subject studies with strong research rigor, 3 different research teams in 3 different locations. Therefore, this systematic review cannot claim CBT as an evidence-based practice for this population. So what are the implications, or what does this mean really in real life? So CBT is both a cognitive and behavioral therapy, which all of the elements that are established within it are an evidence-based practice. So Rosen et al. 2016 had evidence supporting behavioral approaches in reducing anxiety for those on the autism spectrum with an IDD. And treatment components from what we saw were largely based on behavior analytic literature, so such as reinforcement, desensitization, stimulus fading, differential reinforcement of alternative behaviors. So really this review provides a small step towards extending this research to those with a mild intellectual disability, and that clinically we can recognize the overlap of strategies to develop more comprehensive family-centered positive behavior plans. The limitations were really that most of the studies, 4 out of the 6, had poor methodological rigor. Only 1 study received a high quality rating. Additionally, there was lack of treatment fidelity, or IOA, within the studies. And then the range of anxiety measures. So it's really outside the scope of this review, but 12 different assessment methods were used, and there's not currently a consensus on best practice for evaluating or diagnosing anxiety in that population. So future research should focus on improving the methodological rigor, continue to strengthen the literature supporting the use of CBT. Replication, so Blakely et al. And Moskowitz et al. Provided a really great framework to guide future research to strengthen the literature supporting the use of CBT for the autistic population with IDD. And then lastly, component analysis. So there was so many treatment components included in each study, so really to understand what were the effective components within each review. So conclusion, this review provides a summary and guidance for future researchers evaluating the treatment of anxiety. Understanding the presentation of anxiety in autistic individuals with an IDD creates unique challenges and barriers to treatment. Individuals on the autism spectrum may demonstrate typical and atypical presentations of anxiety. And then future research is needed to focus on strengthening the literature in an aim to develop an evidence-based practice for this population. Here is my information and references. Thank you.
Thank you, Monica. So now it's my turn to present my research. My research title is Teaching Complex Intraverbal Verbal Behavior to 3 School-Going Children with Autism. I would like to thank, can you see? Yes. I'd like to thank my co-authors who are participating in the research. So language development, a study of language development in neurotypical children suggests that by the time children are 5 years of age, they can engage in complex intraverbal communication and respond to reciprocal conversation with a high level of verbal conditional discrimination, such as talking on topical conversations or storytelling. Sundberg, they suggested that children with autism acquire MANs, TACs, and simple intraverbals, however, have immense difficulties with compound verbal stimuli and multiple control due to restricted stimulus control. Speaker and listener behavior uh, involves responding to multiple components of an antecedent stimulus, which is evoked by the speaker, and when two or more stimuli could either jointly affect a response, or one stimuli can alter the response due to its effect on another stimuli. When a child with ASD responds to the question, "How are you?" or "How old are you?" with the answer, "I'm fine," we can say one component of the antecedent stimulus, "you," has gained stimulus control and evokes a faulty response to any statement ending with "you." We can also say all components of the verbal antecedent did not gain stimulus control over the response. Axe and colleagues, they suggested that such errors are caused due to the restricted stimulus control caused by the failure to establish conditional discrimination. Michael and colleagues in their 2011 paper review Skinner's concept on multiple control, and they say that Skinner's 1957 taxonomy of verbal operants does not exist in its pure form. Verbal behavior includes interaction of several controlling variables acting concurrently in the real world. They suggest two types of control: convergent multiple control and divergent multiple control. And this would be an example of convergent multiple control, where the response is tiger in different situations: stacked, text, reading text, echo, or intraverbal. And a divergent multiple control would be when a statement like "a rainy day" may evoke multiple responses, such as umbrella or cancelled picnic or boots, etc. Ikeset and colleagues in 2013 suggested the difficulties in acquisition of intraverbal behavior in children with autism may be due to the way we teach intraverbal responding. So they suggested the three types of stimulus control relevant for acquiring intraverbals, and these are as discriminated operants, where they said that an ST such as ready, steady will be followed by one response, go, uh, or as a compound verbal stimuli, where the example would be name a spotted animal, where the listener's behavior has to come under the control of both SD, spotted, and animal to evoke a correct response. The third type involves conditional discriminations, such as if we say, "If you are studying ABA at QUB, you will get a discount." And this is about complex conditional discrimination. So, uh, Ingvarsson and colleagues in 2016 tried to establish complex stimulus control over intraverbal responses in 4 boys who were having great difficulties with learning intraverbals. They used a block trial procedure to establish conditional discrimination between question pairs, such as "what do you play, what do you play with," "what do you sweep, what do you sweep with," or "what do you color, what do you color with." And in this study, we did a systematic replication of the previous study by Ingvarsson et al. And our research questions were: if we teach divergent responses for one question, for example, "tell me things that you wash," and we also train for each stimulus relation, such as "you wash clothes with," "you wash hands with," "you wash glass with," would the student be able to respond to divergent discriminated responses, such as "tell me things that you wash" and "things you wash with," without direct training in children with autism? And the second research question that we had was, would we observe generalization effects for Other question pairs, such as what do you eat with, or what do you play with, without direct teaching. Eventually, we really wanted to find out what can be an efficient method for teaching multiple control in children with autism. The participant selection criteria we had was having children with autism who were receiving therapy at our center at Behaviour Momentum India. They needed to have low scores on the VB MAP intraverbal subtest group 5 to 8, along with a customized intraverbal assessment that we did. And there should be absence of challenging behavior so that we could focus on language development. We identified 3 participants, all male, between the ages of 5.1 years and 10.5 years. All were studying in a mainstream school with a facilitator support, and their VBMAP scores ranged between 150 to 166, which is not very variable. All were on level 2 and level 3. The VBMAP intraverbal subtest scores on subtest 1 to 3, was above 93% for all 3 of them, however, was fairly low on subtest 4 to 8. Some of the responses that they gave when we asked them, where do you go if you're sick? And that was a correct response, hospital. But when we asked, why do you wear a coat? The response was in the winter season. If you look at SW, when asked, what do birds make? He said, fly. And when VI was asked, what is your last name? He said his first name. So the setting and material that we had was RY and SW. They attended this study on telehealth via telehealth, whereas VI attended the clinic. Sessions were held 5 days per week on PowerPoint presentations, and an individualized reinforcement system was available for all of them. The responses were measured for baseline and intervention probes in the following sequence. The initial probe was made on all question pair probes, where each student was asked to respond to questions like eat and eat with, cut and cut with. So all the pairs were probed on. This was followed by assessing for divergent responding to question 1, things you wash. This was followed by a probe on when criteria was met for divergent responding on question 1. A probe was conducted on stimulus relations, like what do you wash hands with, what do you wash clothes with, what do you wash hair with. And after criterion was met on all the 3, on divergent responding to question 1 and stimulus relations, post-training probes were conducted on discriminated divergent responding. And here we assessed for when we asked without teaching, what do you wash versus what do you wash with? And finally, an all question pair probe was conducted once criterion was met on the above. Data was collected as yes and no, prompted and independent responses, and trials to criterion was measured. 100% correct independent responses were expected for mastery on the criterion. The experimental design included a multiple probe design, multiple baseline across question pairs for each participant, and a pre-post test design for all question pairs. So the step 1 here was about training divergent responding to question 1. A slide was presented with all the pictures, and the ST was what do you wash? And response was hair, hands, clothes, and glass. Each slide was followed by an empty slide for a tag to intraverbal transfer trial. So training for divergent responses was done for question 1, and there were only 8 trials which were conducted. A tag to intraverbal transfer trial was conducted. Picture stimuli were varied and presented in a quasi-random order, and a 0-second verbal prompt was provided during training. After 8 trials, an immediate probe was conducted for intraverbal responses on 4 trials. Once mastery was achieved on the previous step, then the student was probed, and if they did not respond, and then they were trained on stimulus relations. Here we trained them that you wash clothes with what, and the student was expected to say detergent, or you wash hair with shampoo. So 8 trials were conducted for this, 2 for each. Let's look at the results for RY, the first participant. So the all question probe conducted for RY suggested 50% responding. That was to chance. So we were quite clear that there were issues and difficulties with multiple probe. So question 1 was trained on, that is, what do you wash? And by the 4th session, you can see that in the probe session, the student had already acquired 100% responding. This was followed by an assessment on stimulus relations for all the 4 stimulus. What do you wash hands with? What do you wash clothes with? And this also suggested that the child was not able to respond 100%. So training was conducted, and within 2 sessions, by the 3rd session, he had acquired the stimulus relations. What do you wash dash with? This was followed by an assessment and a probe on the discriminated divergent response, that is, what do you wash or what do you wash with? And here again, we see that in the probe that the student didn't know. So after 5 sessions of training on the probe, he had acquired all the responses. An assessment on a set 2, what do you cut, did not require any training. And without any training, he already responded to what do you cut paper with and what do you cut nails with, which is the stimulus response relation. Finally, on the discriminated divergent probe, what do you cut or cut with? Again, there was no training required. In set 3, for this participant, when asked what do you eat, he required just 1 session, and in the probe, he was able to respond correctly. He required a little bit of training for the stimulus relation. What do you eat noodles with? What do you eat burger with? And finally, the discriminated and divergent responding was acquired without direct training. Now, here I'm going to show you a video, and I hope it's going to work. I can't hear. Can you hear it?
We wash with their hair.
Okay.
We wash
Great.
clothes with.
We wash clothes.
Okay. You wash hands with.
Soap.
Okay, Ryan, that's correct. What do you wash?
I'm going to go to the second video now. And this is after training.
Lovely. Tell me some things you cut with.
Nail cutter, scissors, axe, and knife.
Cool. Tell me some things you wash with.
Shampoo, cologne, detergent, and soap.
Cool. Tell me some things you cut.
So I'm going
Paper
to
nails,
stop
wooden.
sharing this also, and I will go back to my presentation. Okay. Oh, I'm sorry. How do I do this? Okay.
What do you wash hair with?
Hair, glass, clothing.
The second participant, we had to similarly, on the all question pair, he didn't respond. He was trained on the first stimulus set, what do you wash? Followed by the probe. He was trained, no, he did not need training actually, but just 2 presentations were made, and he responded without training for what do you wash hair with, what do you wash clothes with. And when we did the discriminated divergent discriminated responding with what do you wash and what do you wash with, he was able to acquire correctly without teaching. However, on the all question probe, he was not able to respond. On the second set, when we trained what do you cut and cut with, he was able to respond on discriminated and divergent responding what do you cut and cut with without training. Now, I go to the third participant was present only for one set, and he also needed training only for the first set, which is what do you wash? And after that, when we assessed for the stimulus relations and for the discriminated divergent responding, he responded correctly to all of them. So if we look at RY, we see that while in baseline, you can see he responded only to about 40% correctly. After training, he was trained on 3 sets: eat with, cut with, and wash with, and he emerged without training for play and play with, and eat on and play on. When we looked at the trials to criterion, we found that for the first set, the first 2 participants actually required a lot of training, but after that, the second set and the third set, they didn't require, the trials to criterion was quite low. When we compared the trials to criterion with the Ingvarson and Kulig study, we found that the participants in our study actually took much lesser time and trials to criterion for acquiring multiple control and discriminated divergent responding. So, what we found in the study was that multiple exemplar training on divergent responses can lead to generalization effects if we start teaching children with autism right in the beginning, considering multiple exemplar training. The second thing that we found was that in the Ingvarson study, they had used prompts, intraverbal prompts, and they did not use picture stimuli as tags. And we used tags, and then we did the intraverbal transfer trials, and that could have helped reducing the trials to criterion. The training was in a quasi-random order was also effective because there was no rote learning going on here. And finally, telehealth training can be effective for teaching complex intraverbal responding. We can also conclude that discriminated and divergent responding can be acquired without direct intervention if multiple exemplar training using tag to intraverbal transfer trials is included in the training. There are quite a few limitations in the study. One of them is training across 3 sets could be completed with only 1 student. Till this presentation was done, the second student went up to set 2 and then he left, and the third student left after set 1. So individual differences also need to be studied in further detail. While their scores were fairly similar on the intraverbal subtest as well as the VB map, still there seems to be some individual difference because some children acquired skills much faster. The intraverbal probe trials should not have included the prompting as it affected our trials to criterion. And after the training, the intraverbal probe should have been simply intraverbal without the prompt. And finally, training via telehealth could impact trials to criterion, and that's an assumption that we are making here. So while this study demonstrated an efficient method, more research needs to be done in this area. These are the references for you. Thank you very much. That takes care of my presentation. Now, I would like to call Rahma. Rahma, are you there? So are you ready to start? So our 4th participant on this paper is Rahma Farah, who's presenting this study with Dr. Nichola Booth. And this is another interesting study we're looking forward to. Yes, please.
Hello, everyone. Can you see these slides? Is that okay? Have I shared it? Okay. Okay, I'm going to reshare it again. I'm going to stop sharing. Okay, is that better? Okay, brilliant. Good afternoon, everyone. Apologies for the technicality. My name is Rahma Farah, and I've recently completed Masters in Applied Behaviour Analysis with Queen's University Belfast, and I would like to provide a brief overview of my dissertation, which was to explore the combination of hand gesture cues and ABA principles to improve speech intelligibility. I intend to cover the following content. I would like to start by providing an introduction and rationale of the dissertation. I'd like to summarize the ABA strategies that support speech intelligibility, as well as summarize a few of the speech and language therapy strategies that support speech intelligibility, and provide a summary of those strategies and highlight a few limitations. I'd also like to state the research questions posed in the dissertation, the methodology I carried out, as well as highlight a few of the results and the main discussions and any conclusions that were drawn. And finally, I'd like to leave with any further research and recommendations. A systematic literature review was carried out to explore the combination of hand gesture cues and ABA principles to improve speech intelligibility of autistic individuals. By speech intelligibility, I refer to the degree to which speech sounds are correctly identified and understood by the listener. Why this SLR? This mainly came from my clinical experience of working with autistic individuals at an ABA clinic, wherein I was asked by the ABA consultant to include cued articulation, which is a type of hand gesture cues, with a child that presented with autism and speech difficulty. I found that the client made marked improvement in their speech production and clarity. I did find outside of this practice, there was some hesitance from ABA professionals to include or implement hand gesture cues with speech difficulty clients. This could be due to a lack of awareness of this strategy and can be closely linked to a lack of literature in this particular topic. And this then sparked my motivation to research the gap in the literature. There's a wide range of established ABA strategies that support speech intelligibility, speech development, as reviewed by Mulhern et al. In 2017. Of those strategies, vocal imitation and echoic training is one of them. Vocal imitation is one of the earliest research in language acquisition, as effective imitation will allow successful teaching of other verbal operants such as tact, labeling, requesting, mand, interverbal, listener responding, and textual skills to enhance verbal behavior. Therefore, one way to improve vocalization would be through successful vocal imitation and echoing target vocals and shape them accordingly. Strategies to support acquisition could be discrete route training. Discrete route training helps individual attain target vocals through error correction, which is where you represent the stimulus, and errorless teaching, where you prompt the individual before they error, and removing the prompt to establish stimulus transfer control. Shaping is another ABA principle that allows the differential reinforcement of vocals as they make closer approximation to target vocals. Stimulus-stimulus pairing include pairing speech sound with unconditioned or conditioned preferred item, a reinforcer, to enable the speech sound to be conditioned with a reinforcer. A few prompting strategies, one of them could be time delay. And this is where this can be implemented by including a vocal response and giving a certain time delay to before providing a vocal prompt. Another prompt strategy could be the lip-tongue-mouth prompt, as utilized by Eikerseth and Nesseth 2003, to model the mouth, the lip, the tongue and teeth position when presenting target vocals. The speech and language therapy field focuses on the diagnosis and intervention of communication and swallowing disorders of individuals, which can include all deficits related to speech and swallowing disorders. The two main kinds of intervention are phonological and articulation therapy. And although there has been a recent paradigm to utilize and pay more attention towards the phonological treatments, articulation therapy still holds importance, and this SLR focused on articulation therapy as it is more concerned with correcting speech. And of those could be auditory discrimination, which include hand gesture cues, such as cued articulation, cued speech, and adapted cueing treatment. Cued articulation was first devised by Jane Passy in 1970 to support individuals facing difficulty in producing functional speech sounds. This consists of hand cues that illustrate where each speech sound is produced and whether they are voiced and voiceless. So this is a brief overview of Jane Passy and her hand movements. These are cued vowels. She also has cued consonants. And I suggest maybe looking at YouTube, where she will show you physically how these cues are articulated. An example could be a for ant. Cued speech was first developed by Orrin Cornett in 1966 for the deaf and hard of hearing population as a communicative tool to represent the visual version of the English language. Leibart 2015 stipulates that cued speech can also be useful to shape vocal production of sounds, and that is, it can support any individual that face speech difficulty. This is just a brief overview of the ABA strategies, as well as the SLT strategies. Another type of hand gesture cue is adapted cueing treatment, which is a visual cueing system that enables the production of phonemes that is intelligible to listener. This includes the movement of the finger and hands across one's face to represent each speech sound. While the literature has shown that the aforementioned strategies are effective in supporting speech development and intelligibility, they're not short of limitations. Of those limitations, in the ABA discipline, some individuals may not have the echoic repertoire, hence vocal imitation and echoic training may be ineffective. Stimulus-stimulus pairing does not necessarily pinpoint clear vocalization, rather they could increase in the evoking of vocals. Prompting and shaping strategies do not tackle where to produce target vocalization, and therefore they may not improve speech intelligibility. In the SLT strategies, most SLT strategies adopt an eclectic approach where they combine various strategies, and this may be problematic as it fails to pinpoint which particular component is effective in speech intelligibility. There is also a lack of evidence-based treatments that prove this to be effective in the autistic population, as it is predominantly focused in the deaf and hard of hearing. This is where I propose combining the hand gesture cues with ABA principles to support speech intelligibility, as the ABA principles will help strengthen the skill acquisition and generalization, and the hand gesture cues, which is an SLT discipline, can help tackle the underlying nature of speech production. I intended to answer or research the three research questions, one being the ABA prompt strategies that improve speech intelligibility in autistic individuals, two, the hand gesture cues and how they improve speech intelligibility in autistic individuals, and three, whether ABA prompt strategies can be combined with hand gesture cues to improve speech intelligibility in autistic individuals. I utilized various databases made available via the Queen's University Library to search for suitable articles to review. I quickly found that there was a vast research at present relating to ABA strategies on speech difficulty, and I decided to narrow this search to only include studies that utilized a prompt and whether that prompt showed a change in speech intelligibility in their outcomes. This informed me of the kinds of ABA prompting strategies and if hand gesture cues can be incorporated in the future. I utilized the PICO strategies to narrow down which factor in the research papers to focus on, such as the participants, intervention, outcome, study design, and type of publication. Also used the PRISM flowchart to illustrate the phases I went through. So, following the initial search here, I skimmed through the titles and abstract for relevance of the inclusion criteria, and if I found some relevance, I read the methodology and also screened full text. The search was carried out twice. As you can see, the blue writing was for the ABA strategies and the red was for the hand gesture cues. I did find a lot of difficulty to return suitable articles for the hand gesture cues, mainly because it was focused for the deaf population. And lastly, I resulted in 7 articles to review that were related to ABA strategies, and 3 had adopted hand gesture cues. I also used RICO's evaluative method to assess the quality of the selected research articles. Of the 10 articles, 7 utilized ABA strategies, and these were the 7 that I had reviewed. These are the experimental design they adopted, the intervention they implemented, and the outcome. From RICO's assessment, these 7 articles were either deemed as weak I beg your pardon, sorry, they were either deemed as strong or adequate, which is quite promising. The 3 articles reviewed in the SLR utilized hand gesture cues. Schlipp in 1986 utilized cued speech with an 8-year-old child who presented with articulation difficulty of the sounds R and S. And after implementing that strategy, he showed an improvement in the verbal repertoire and reading texts. Roiswick in 2017 included mimicry cues, which is similar to hand gesture cue or a type of, and found an improvement in the articulation. Salo Nobere used 2 interventions, video modeling and cued articulation, and both returned positive feedback in implementing these interventions. The key findings of the discussion were structured to answer the research questions posed. The research question 1, that related to the ABA prompting strategies, revealed that while the interventions did provide a level of improvement in the participants' vocalization, some did not show an improvement after intervention. This supports my proposal of combining an additional prompt, such as hand gesture cues, when conducting ABA therapy to address speech intelligibility. Question 2, related to the hand gesture cues, concluded that the articles utilized cued articulation, cued speech, and mimicry of cues to support speech intelligibility. While they did show an improvement in vocalization, some of the studies did not test for generalization. This suggests that utilizing ABA principles like generalization probes and maintenance can further strengthen these strategies. And lastly, the question pertaining to the combined use of ABA and hand gesture cues, the SLR returned with no research questions on the combined use of hand gesture cues and ABA strategies. However, this reason could be due to the fact that speech intelligibility as a research area combining SLT and ABA did not yet receive attention, therefore warranting empirical research to explore its effectiveness. I'd like to conclude by bringing back something interesting said by Owen Cornett in 1917. He stipulated that the lip, teeth, and tongue provide 2/3 of information of how sounds are identified, while the hand movement supplies the remainder of information required to correctly produce speech sounds. In my conclusion, I proposed a strategy to support ABA professionals when facing with individuals that may be diagnosed with autism and present with speech intelligibility. If the ABA strategy alone or the SLT strategy alone does not result in improvement in their speech, they could use hand gesture cues as a prompt to shape the individual's speech sound. And during the discrete trial training and teaching strategy, they can remove this prompt to establish stimulus transfer control. And finally, I came up with 4 recommendations for further research and recommendations. Firstly, to research the underlying nature of speech intelligibility. Secondly, to conduct experimental design research to determine whether ABA strategy alone or SLT strategy alone, or whether the combined ABA and hand gesture cues, and to find out which of those 3 would be most effective in supporting speech intelligibility. Thirdly, related to the second recommendation, would be to test for generalization and maintenance. And lastly, to further research on the link between autism and speech intelligibility. It is hoped that with all these future recommendations would lead to further successful treatment of speech intelligibility. And I'd like to thank Dr. Nichola for being my dissertation supervisor and Katerina for allowing me to present today. Thank you very much.
Thank you, Rahma. That was really wonderful. and maybe all of us can be here. We have about 12 minutes. So if anyone has any questions, we can answer the questions. I, for one, really enjoyed all the presentations. They are so relevant in what we do with children with autism. I'm really excited to see some of these being published, and we have an opportunity. Anxiety, teaching communication, all of these are very, very interesting works, population we work with. So I don't see any questions, so maybe we can leave. Which telehealth platform did we use? We used Zoom for this. So we were using Zoom during the COVID pandemic time, and initially we were doing Skype, and then that was not working very well because Zoom was banned in India. So we were really having a lot of difficulty. A lot of our children were actually working on their smartphones, so we really struggled a lot. Sometimes some of the sessions were also done on WhatsApp video. So we had to be really flexible during that period. We had subscribed to Zoom, so it was not for healthcare. It was just Zoom that we were using. Zoom with subscription.
Yeah, there's a question there about is Facing Your Fears and Calm Child program for specific age children? So I believe off the top of my memory, Facing Your Fears is aged for around 7 to 12. And the Calm Child program does not have a specific age range. It was just a pilot study, and they used it with adolescents, so with teenagers.
I have a question for ELENA. ELENA, when you were conducting those experiments, I saw that the improvements in the ABC format was actually the slowest. Any particular reason for that?
Yes, yes, that was unpleasant for me as well. I think that I had a poorer definition of ABC format since the atmosphere was so naturalistic and it was based purely on play. The reinforcement oftentimes was just the continuing of the activity, and it was difficult to actually individualize, to actually point to the reinforcement. So those data were kind of blurry. So we are doing replication now, and I revised the definition. Hopefully data will be clearer, but I suspect that was mainly due to a poor definition that implied poor scoring, and so we had poor results.
It was very interesting because all the other areas, the improvement was pretty good. I mean,
Yes.
almost reaching above criterion 80% and above, but ABC was really slow. And I guess that is happening mainly because of taking data in the natural environment.
Yes,
So
it's
it was
difficult.
just
We took data on the videos, so it was possible for us to review and to revise the sessions, but still is a lot easier to confidently take data on where the toys are or where the parent is placed in the environment than if the continuation of the activity or a smile or tickles are to be considered reinforcement for the opening, for the social opening, or the parent would just do it because that was the topic of the play chain. So yes, we really need to revise that section and provide better guidance and better data and better scoring guidelines. Thank you for addressing that.
Thank you. So I think we can then leave. Thank you, everyone. Thank you, Katerina. Thank you, Dr. Karola. It was a pleasure being here. We have time to say thank you to everybody.
Thank you.
Thank you, Chris, for your help. I think I'm going to end the stream now.